Welcome to the Virtual Shift, a show looking at the seismic changes happening in healthcare with virtual care at the epicenter. Join me and my guests as we look at key cultural and policy shifts impacting how providers, payers, and patients connect, as well as how care is being reimagined both for today and the future. Hello, and thanks for tuning in today. I'm your host, Tom Foley. You can learn more about this show by visiting the program on healthcarenowradio.com, and be sure to follow me on LinkedIn, Twitter at FoleyTom, and the hashtag The Virtual Shift. Today we have a very special guest, Mei Kwong. She is the Executive Director at the Center of Connected Health Policy. Mei, welcome to the program.
Thank you for having me, Tom.
Awesome. So Mei, tell us a little bit about the Center of Connected Health.
So the Center for Connected Health Policy, or CCHP, is the federally designated National Telehealth Policy Resource Center. So what that means is we receive federal funding to provide technical assistance to people who have questions regarding telehealth policy, the laws, the reimbursement policies, things like that. And we help everybody from, we've helped everybody from the White House to congressional members to state lawmakers to health plans, health insurers, companies, doctors. And during the COVID pandemic, we actually were talking more and more with patients who were curious as what telehealth was, how they can receive services via telehealth, and just in general, getting general information regarding telehealth.
So in the hierarchy of things, there are regional centers as well, and you're at the national center. Is that correct?
Yes, there's actually 14 telehealth resource centers. We're underneath the same program of funding from HRSA, from the federal government, 12 regional resource centers, and they cover specific states. And I like to call them the front line, essentially. So most people typically reach out to the regional resource centers because they're located in, their specific states, or they cover their specific states. But whenever those regional resource centers run into questions regarding policy that they can't answer, they elevate it to CCHP to do it. And there's also another national center on technology. So when they run into technology questions that they can't answer, they can refer them to the National Technology Center.
Awesome. So there's a number of different, HRSA in and of itself provides grant opportunities for health systems to embrace an alternative funding mechanism to ultimately launch a telehealth program. Are you involved in that, and how your organization might assist healthcare organizations in that grant process?
So there are a lot of grants now around telehealth, especially during COVID-19, that have come out of HHS, and a lot of them have come out of HRSA as well. The ones that you're referring to is where they may be looking at different models on how you use telehealth and how that is basically kept sustainable, how it's funded. The way we would help in something like that is not necessarily in helping somebody apply for that particular grant. What we may do is afterwards, when a grantee has, received approval and is receiving funding, if they have questions regarding something related to policy, at least that would be what CCHP would do. For example, maybe they have their particular pilot project is looking at serving a Medicaid population. So maybe they might have questions regarding their state Medicaid programs that they were unfamiliar with. They may reach out to CCHP regarding that.
Interesting. So there has certainly been a lot of attention on telehealth / virtual care in the onset of the pandemic, and hopefully we're not going to receive that pandemic anytime soon with the numbers going down. But nonetheless, it did educate the market, both the consumers, as you referenced earlier, and the health systems, on there is truly an alternative way of delivering care. So tell us a little bit about some policies that you might be working on at the national level that might influence the furtherance of such a use of delivery of care.
Well, Tom, you're absolutely right. The pandemic did raise the profile of telehealth and make it more sort of, put it on the radar for a lot more people than where it was before the pandemic. Early in the pandemic, I likened it to, that unknown actor that, maybe you've seen in a couple of things, but you didn't recognize their name, suddenly getting cast in a Marvel movie as the star or something. Suddenly, they're everywhere, their name. So that was a little bit like the telehealth experience. I also want to make sure that people understand that CCHP does not lobby. So we don't advocate for a particular position on like the lobbying side of things. We provide educational resources, technical assistance. We are sometimes called upon by lawmakers when they have questions about policy. So we probably do have an impact on that, in that we provide those educational resources. And we're also unique in that we have this very federal, but we also cover all 50 states and the District of Columbia. So we know things about what's going on the federal level and the state level. So we have kind of this bird's eye view of all the different policy landscapes and what's going on. So I can tell you right now, policymakers are trying to make a decision on, like, what are we going to do once we get through the pandemic? We did a lot of this temporary policy stuff around telehealth. What are we going to keep around? What's going to be useful here? But they're also balancing it with, we want to make sure that whatever we do, nobody's going to be adversely affected. So if they roll back things, they want to make sure that nobody's going to really lose care. But if they keep it around, they also don't want to inadvertently adversely impact somebody because maybe they're not able to access telehealth because whatever reason, bad connectivity, income, whatever. So they're weighing all these things. But where people are now is a lot of states have decided, this is what we're doing. So they've made those decisions. The feds, at least with the Medicare policy, they kind of delayed it a little bit. So recently the budget for 2022 was passed, and there was a section in there regarding the temporary policies on the federal level where they said, we'll keep it around for 151 days, certain telehealth temporary policies that we allowed during COVID. We'll keep it around for 151 days after the federal public health emergency is declared over. So they have a bit of a cushion there to try to decide on what will be the permanent policy on the federal level. States, as I said, some of them have already made their permanent decisions, but that doesn't mean they may not come back during another session and change that. And then, a couple of other states have also done that. We'll delay it for until the end of 2022. We'll keep the temporary stuff around, or we'll delay it 2 years out. So it gives us more time to study it and gather data to inform a more permanent decision.
We often talk about telehealth,
mm-hmm.
and I look at that as video and asynchronous or synchronous video. So it's part of the solution, but it's not the solution. And you hear reports or studies that telehealth visits are down. So it gives this connotation of it's a blimp on the radar of something that we could have done, right? But when you take a look at this whole path to value. And the biggest challenge for providers is, how do we extend care from their brick and mortar facility into the home? Because we also talk about, in the context of value, is the home becoming a setting of care. Mm-hmm. So telehealth is part of that, but you also have remote patient monitoring, remote therapeutic monitoring, chronic care management. A provider looking at that full spectrum of virtual care, inclusive of telehealth, can extend their delivery of care model into the home. I refer to that as a continuous care model, right? So now they can enhance the delivery of care. They can actually make some money, right? Nothing happens in healthcare unless they get paid. It's true, sad but true. But the point there is that, but the patient themselves can realize a better quality of care, because now it's not just about the time I spend in the brick and mortar facility. It's about my provider actually providing services, hypothetically, on a 24/7 basis. So it gives me the coaching and the support mechanism for me to change my behavior, because that's what the path to wellness is all about, is really changing the behavior. Right? Mm-hmm. Taking your meds, exercising, dieting, right? All those count relative to how do I get to wellness. The point there being is this continuous care model. I can do all of that: telehealth, remote patient monitoring, remote therapeutic monitoring, chronic care management. I can take all that on, change my whole delivery of care model without taking on any risk. Because it might be a capitated model, but it's still not a risk model. The point there being is, I look at continuous care as the stepping stone to value-based care. So providers don't have to jump from episodic to risk. They can jump to continuous care, feel it, sense it, deliver it in the context of true care delivery into the home, and then go to a value-based care model. Thoughts on that?
Well, That's actually a bigger question than telehealth. What I think telehealth has done is help shine a light on really the larger question of like, how do we deliver care in our US health system? And that's more of a larger philosophical and also, operational question than just around telehealth. Telehealth is a tool that can be used to, go with these new models of care, go with these new systems here. But we're humans. A lot of us don't like change, and this is like a bit of a significant change. I mean, really, the only reason telehealth was adopted was it was a forced change because of the pandemic. So now what you're talking about here is that telehealth has kind of helped shine one of the lights on this. I mean, there's like a bunch of different factors that are involved in this discussion of why people are like, trying to think of new ways of delivering care, and also like, their operations, unlike how they do that. So I think what we're talking about here is larger than telehealth itself. Telehealth is an element to it. It's a tool that can like definitely help push that conversation forward and like regarding these new models. I mean, this is kind of like the second question you've asked me about new models, and that's been something that was being discussed before COVID. COVID's
Right.
kind of helped accelerated that discussion a little bit of like, you know what, we got some evidence here that telehealth does indeed work, because there were a lot of skeptics before the pandemic. Telehealth does indeed work. Doesn't work for every situation, and even as a telehealth proponent, I admit that it's like it's not going to be appropriate for every
Absolutely.
single situation.
Absolutely.
Like,
I'm
you're
with you.
still going to need that in-person stuff. But it has pushed things forward into maybe what we were doing before, where it's like I come in for my appointment, I see my doctor, and that's how it is. Maybe that's not the most efficient way or the best way to deliver care to someone. I have elderly parents. One of them has multiple chronic conditions. Before the pandemic, it was the whole brick and mortar type of visits and everything. Because of the pandemic, it's my mother. She's very vulnerable population to COVID. So they were just like, we're shifting you over to telehealth. And she loved it. So now that whole thing, the whole thing was, there's whole other debate here, because she would not have been able to do the technology unless I was there helping facilitate her. But that's another discussion there. But it worked better for her, not only because we were in the pandemic situation, but she has that, is it called white coat syndrome, where you go in and you're anxious, and then you just get like all these elevated readings, like high blood pressure and stuff like that
Exactly.
when we go to the doctor. So when she was at home, she was much calmer, so they were able to get more accurate readings from her on like what her condition was. So there are those patients where if you do move to this new model of care, it's going to benefit them enormously, as you mentioned, because not only do you get that continuous care, but you may actually get more accurate information from utilizing telehealth because of certain patients and the way they react.
Interesting. If you're just tuning in, you're listening to The Virtual Shift. I'm your host, Tom Foley. I have a guest, Mei Kwong. She is the executive director at the Center of Connected Health Policy. So, looking at that, I totally agree on many points that you just made, if not all of them. And the major one is virtual care does not replace brick and mortar. It is an extension of care, in my view. You leverage it where it has value. You leverage each tool that you have in your bag as appropriately needed to maximize that patient's path to wellness. Absolutely agree. And I do agree that the home creates a sense of a calmer sense, or more comfortable with it. I didn't rush through traffic, and I wasn't late for the appointment, and I didn't have to wait in the waiting room for an hour to see the doctor. Right? It all builds up anxiety and things of that nature. But at the same time, I have an 84-year-old mother-in-law who's having some challenges, and she needs to go see a doctor because she has a lot of pain, but she's got to wait 3 weeks to go see them, right? So and virtual care can help or doesn't help, but the point is that care. I'm sick now, right? And so I need to. It goes back to your earlier point of, which I think is really the crux of the conversation here, is the word change, right? I just came back from HIMSS, and it was all about reimagining the delivery of care. We can reimagine it as often as you'd like, with all due respect to the theme. I do agree with it, but if you don't have a delivery of care model that embraces change, and if you don't have a patient base that embraces change, all this investment is going nowhere, right? Because at the end of the day, I always say, hey, sit around the Thanksgiving Day table with your neighbors, friends, family, friends, and neighbors, and ask them if they know anything about value-based care, right? And the argument is that they don't know, right? So if the patient doesn't know they're engaged with a provider that's in a value-based care model, risk-oriented, they don't know that they have any obligation, right? They're just practicing their own care in the context of, yeah, he prescribed me, or she prescribed, my doctor prescribed me something, but I didn't go to the pharmacy and pick it up, right? They said the diet, I don't know. My father was a diabetic. He had dialysis at home. We quickly, in the last 5 years of his life, turned the dining room into a bedroom, had to put a bathroom downstairs, had 3 different amputations, both legs, arm, and a couple fingers. So I get the, if you don't pay attention to what your doctor says, it hurts. It'll hurt in the end. It may not hurt now, but it's going to hurt in the end. So, change in behavior, both from the physician side in the adoption and reimagining the delivery of care and having some level of confidence to do it, and the patient being aware of their condition and what truly the results could be, I think is kind of situational, if that's the right phrase, in that we need to do a better job of educating everybody. Thoughts on that?
No, definitely. I agree with you. So one of my big things, at least where telehealth is concerned, I said there needs to be education both not only on the provider side, but really on the consumer side, on like what exactly it is, what it can do, what its limitations are, and and how they can access it. But I think in general, I think Americans in general just really have poor healthcare education levels, just because there's just like no concerted effort to provide that education. And also, when you go to a doctor or you're in the hospital or something, you're probably not in the best frame of mind to like intake all of that information. Again, I've had family members who have been in the hospital and they're sick, they're scared, they're completely out of it. They're not understanding what's going on or making decisions. You really do need like that advocate with their family member, friend, whatever, to like take that in, preferably like maybe 2 people, just because it's always possible to like miss something there. But you need that in almost every situation, in that you need kind of like that other person to be that other set of ears, and also not to, maybe they are also feeling anxiety, but they're not that person whose condition is being talked about. So they have a different level of anxiety, and maybe they're able to hear things a little bit clearer.
Yeah. And that's the one major deficit in the encounter-based care model, right?
Yeah.
I always think again of my father, my mother, and others who have needed care. And if you're not your own advocate, it's challenging. And I start to think about those that don't have that support system. And because in the episodic care model, as soon as you walk out that door, next, right?
Yeah.
So it's really challenging about what we really need to do to change the overall processes and engagement level to ensure that we are not a reactive healthcare system, but a proactive wellness system.
Yeah. And the thing is also, looking at our healthcare system now, coming out of hopefully coming out of the pandemic, not good, people are burnt out. Our healthcare workers are burnt out. I mean, Not only did they have to deal with the pandemic, they've also had to deal with, hostile forces of people who didn't believe in COVID or were angry, and they were taking it from all sides. To ask them to do that continuous amount of care and like be able to do that follow up. You probably we've got a shortage. We were going in with a shortage before on healthcare workers.
Exactly.
Now you've got like a workforce that's burnt out. A lot of people are like leaving the workforce, so you have like an even greater shortage. What are you going to do now with that? Like, you've got even less people to help ensure that continuity of care throughout like somebody's recovery. Again, speaking from a personal standpoint, I've had family members who have had serious conditions where they're discharged from the hospital, but there's still care needed in order for a full recovery, like weeks and months afterwards. And you're right. I mean, one of the saddest things, like when my family members were going through this and I was in the hospital, was seeing other patients who didn't have somebody there who was like their advocate, who was, sitting there, making sure things. I mean, like one family member, there was like a couple of times where like, oh no, he should be receiving his medication now. I know the schedule of his medication, so go get it. So, I mean, but not having that and then going home and not having that more, you can't assure that this person will have a full recovery. So, for, let's say somebody says like, well, what does that matter? It's one person. It's like, you know what, where it might matter is then they become a burden then on the system. So then you're talking about a patient who may have had a full recovery and may not have needed continuous medical care, draining, funds from either Medicare or Medicaid or something like that. When you just didn't want to invest, maybe like, oh, maybe we invest a little bit more in these 2 months to ensure that we do not have somebody who may then need years of follow-up care.
Yeah.
So I don't know the solution to that, because I do have concerns in that we've got a workforce that's burnt out. People are leaving the workforce. It was already a workforce that was a little bit, was probably not adequate for the needs of this country. And now to say, especially with the concerns about long COVID, of people needing even more care afterwards that are outside of like, a facility, how are we going to deal with all that? Because one thing about healthcare workforce is like you can't just suddenly create them overnight. It takes years for their training in order until they are like able to like provide that care. So what are we going to do in that meantime?
Exactly. I have always said many times in this program, we have an older, ager, sicker population, less doctors and nurses. That is the true crisis in healthcare. And that is the true foundation as to why we need to reimagine the delivery of care. We could talk about how to get the value. I'm not opposed to that, but the bigger problem is, before we even get to that, is older, ager, sicker, less doctors and nurses. We have to reimagine the delivery of care, and we have to leverage the patient where they are. We'll call it the home for now. So with all that, I'm an advocate of everything is possible when policy changes. And we know that from COVID, because we had a slew of policy changes that ultimately brought telehealth to its forefront, right? It would not have happened without policy change. So the point is, what can we do? You're leading the charge at the center of connected health policy. What can we do as listeners to help advocate for additional policy changes to move this transformation forward?
Well, really, it is speaking with your representative, both your state representative, as far as like state legislature, and whoever represents you in Congress as well, and letting them know. And it's really telling your story. For example, I'm a telehealth policy person, and while they do come to me for information and everything, they really want to hear more from the providers, like doctors, physical therapists, occupational therapists, nurses, and the patients on like, how has this impacted your life, and what would happen if it was suddenly gone the next day? Like, what would be the impact? They only listen to me so far as far as a policy person. They really want to know, like, what is the impact on people?
Yeah, I don't disagree with you. I come from Jersey, and I had some good experiences working with assemblymen and congresswomen to help make a change. I live in the 17th district here in Florida. I've reached out several times and I can't get a response. Right. So I'm not arguing or complaining. I'm just saying sometimes they don't, we need to do a better job as Congress, is to just listen to your people as opposed to your party, with all due respect. But it does take a village. You can be upset because of the origin of that phraseology or not, but it does take a village, and we all have to come to the center of the table and make things happen. Thoughts on that in closing?
Yeah, I mean, I think it always works better, and it's always easier when you get a big coalition of different folks all saying like, we want X, the same thing. And that has been really like a beautiful feature of telehealth. It's like you really don't find a whole lot of people like that disagree with it. It's like, no, a lot of people see its value. It's popular across both sides of the aisle. The resistance or like the lack of attention you may have encountered, it is a little bit more on people's radars than other people that could also be part of it. So I think it is good that you do reach out to different groups regarding this. And COVID has definitely like highlighted it for a wide variety of audiences. In the beginning of the pandemic, I was getting calls from people who are like, oh, I've never spoken to you before, and now suddenly you're interested about telehealth. And so there are those folks out there. And I would say also, don't limit yourself to like the usual suspects. You might think like, oh, I'm going to talk to doctors, nurses, like, healthcare institutions. There's a lot of folks outside who health may not be in their name, or sort of like aren't sort of what you would think of when you're talking about health as having some sort of stake or interest in telehealth. For example, environmental groups, because telehealth reduces traffic going to your doctor's office. People are staying stationary, so they may be interested in telehealth. Different population groups were definitely the ones that were reaching out to me at the beginning of the pandemic, where they're like, we never really considered telehealth to be like something that we were interested in, but now, because of COVID, we're forced to like look at it. So different population groups, such as one of the big groups that reached out to me at the beginning of COVID, were college health programs, because
Interesting.
they were sending students home, but the students still wanted to receive care from like their health program at their colleges or universities. And they're like, how do we do that? It's like, well, you're probably going to run into licensing issues here if they're like from
Exactly.
So,
Exactly.
but it was suddenly on their radar because they had to do it. So there's all these different groups that suddenly are like, have found out about telehealth and then realize like, you know what, these could really help like the people that we are trying to help, or it can be used for the people that we represent. So I say think beyond sort of, who you would go to in like trying to build coalitions or groups to support a particular bill or position or idea or concept.
Awesome. They are some great recommendations. I do appreciate you spending 30 minutes with us to be on this program. Thank you for your insights and your time.
Thank you for having me, Tom.
I would like to thank the show sponsors, both HP and Intel. HP Engage long lifecycle products provide the stability, safety, and security you need, plus flexibility and performance designed for today and tomorrow. As well, Intel would like you to know we're going above and beyond together with new standards for business with the latest Intel vPro processors, delivering what IT needs for performance, security, remote manageability, and stability. And be sure to check out the program page on healthcarenowradio.com. And remember, connect or follow me on LinkedIn, Twitter @FoleyTom, and follow the show's hashtag, The Virtual Shift. I'm Tom Foley. Until the next shift.